discussion this afternoon will deal with problems of special importance to Iowa. And I'd like to set up a few ground rules of our discussion before we get going. We're going to have each of the four members, who I'll introduce in a second, present their talk, and then after each person we'll allow some time for questions for that person. And we'll see how that works. We'll also allow some time at the end for questions which could be directed to any of the members of the panel. Since we got a late start, we're going to have to keep things moving right along. So without further ado, I'll introduce our panel of presenters. On my far left, on your right, is Dr. William R. Bliss, who is a practicing physician here in Ames now, former chairman of the Governor's Advisory Council on Emergency Medical Services here in Ames. On my immediate left is Dr. Paul Seebohm, who is the Associate Executive Dean of the College of Medicine, University of Iowa in Iowa City. On my immediate right is Norman Pavlevsky, who is the Commissioner of Public Health for the state of Iowa in Des Moines. And on my far right is Dr. Thora Runyon, who is the Associate Professor in the Department of Food and Nutrition, Iowa State University here in Ames. Our first presenter will be Dr. Seebohm. I'll give you a little bit of background, and I'd like to apologize to the members of the panel if I leave anything out. I've got rather sketchy notes on these people, and I'd tell them to be sure and add anything that they would like to if I leave anything out that's important. Dr. Seebohm was voted Iowa Internist of the Year award by the Iowa Clinical Society of Internal Medicine in 1976. He is currently the Executive Associate Dean in the College of Medicine at the University of Iowa. He specializes in the study of allergies, and he is currently the chairman of the Committee for Public Education of the Allergy Foundation of America. He is past president of the American Academy of Allergy. He has published extensively and in recent years has been greatly involved in the study and delivery of care, including the chairmanship of the Family Practice Committee of the College of Medicine. Dr. Seebohm will be talking to you today about primary medical care. Dr. Seebohm.
Thank you, Ed. I think I may need a microphone here. I think maybe I'll have to shout to you about it. I might say all those little things about allergy and other activities in the past really have no bearing on what I'm going to talk about today. What was missing, Ed, was that for the last 7 years I've been up to my shoe tops, as they say, in family practice and primary care, and that is the reason I've been asked to discuss this subject on this symposium. The terms primary medicine and primary care have gained wide acceptance in the past decade, particularly here in the United States. But like most new terms, their meaning has evolved and been reshaped with each succeeding author's use, and it's quite possible I will use the term somewhat differently than the members of the program have thought that it might be defined. But it's very important, I think, to begin with, that we not get primary care mixed up with its occasional fellow travelers, namely comprehensive medicine and social medicine, and preventive medicine. Norm's going to talk about preventive medicine later. Community medicine, personal medicine, ambulatory medicine, and family medicine. Today, I suppose I will be concentrating on facets of primary care that would relate to ambulatory medicine and family medicine. The definition of primary medicine has been worked on over the years by one of your previous speakers here the other day, Dr. McGraw, Pellegrino, plus the Millis Commission gave it great attention in 1966 in trying to work out that which the healthcare system of that decade seemed to need to change it from a crisis to a going operation. And the American Academy of Family Practice has also done a great deal on trying to define and add to the definition of primary medicine. Now, to simplify things, I'd just like to make the assumption that primary care per se has three basic characteristics. You might call them 3 C's. First, contact medicine. Ongoing responsibility for the patient regardless of the presence or absence of disease. This is sometimes referred to as continuity or some such title for the patient. And then thirdly, the integration of other health resources involved in patient care with the if a person is involved, it's a coordinator role. So really talking about contact, continuity, first contact, continuity of care, and the coordination of health resources in the management of patients. The family physicians speak very strongly of this, and they recognize the great help and need of other specialists, but they really do not consider that they ever completely lose contact with the patient, and feel it is very important that they continue to participate in the care of the patient, communicating with patient and family, even though the major treatment at any particular time may be under the auspices of another professional. Now I want to pontificate a little bit in relationship to Iowa and primary care as I know it. The key to an effective system for providing primary care level of medical service really is accessibility. To be first contact, the primary care system must provide multiple service points, more or less evenly distributed among the people that it is to serve. Now, since physicians, and I'm a physician, I want to put everything out on the table here, Jerry. I'm a physician chauvinist. So in case there's any question about that, you don't have to beat around the bush. I just want you to know that I think it is very important that the physicians remain, I hate the word team, but that they be captain of the team if there is such a thing, and that they really be the prime mover in anything that is done in the care of patients. I was challenged on this the other day by my president, who said I hadn't quite caught up with the times, that the team leader doesn't always have to be the physician. And I suggested to him that until the 747s are landed by the flight engineer or the stewardess, the physician will be the team physician in medical care, which I thought was pretty good, but he didn't think was very funny, and I see none of you think it's very funny, so I'll probably not repeat that story again. Since physicians play a key role in the provision of primary care, their numbers and geographic distribution are critical elements in the system. Now, the internists and the pediatricians and family physicians are the chief providers of primary care, And of these, the family physicians are the most versatile and therefore really the most suitable for meeting the first contact accessibility requirement, particularly in agricultural or population dispersed areas. Now it became apparent in the 50s and 60s that the general practitioners manning the primary care access points in the healthcare system were not being replaced, and that the trends in training of medical manpower were creating severe specialty maldistribution. The claim was, and the evidence was pretty supportive, although it never got quite as far off here in Iowa as it did elsewhere in the country, that we were training a lot of physicians, but they were all becoming, quote, high-powered specialists, particularly surgical specialists, and that the family physician no longer, or general practitioner, no longer was being produced by the system. Now, starting with the Millis Commission report in 1966, a corrective movement was initiated to reinstate the family doctor into the healthcare system. I talk about that as being the general practitioner being reborn as a family physician. And nobody thinks that's very funny either, but I thought it was pretty good. Our president's been talking a lot about reborn Christians, and I thought a reborn family physician was sort of right in style with the political climate. The family practice specialty was established and accepted by the other specialties, which was a rather significant thing to happen in the late 60s. And family practice education in medical schools and residencies were starting to flourish almost everywhere. That was also a very important phenomenon to have occurred. It was not just a thing that happened in Iowa or Illinois or Kansas, where it all started. Matter of fact, there's good evidence, and we can show you good evidence, that the family practice movement has been far more successful in Iowa than it was and has been in Kansas, where the Kansans thought they had invented it. Now, in Iowa, the Department of Family Practice was formed in the College of Medicine, and a network of residencies throughout the state was organized. And if I could have the first slide, I don't think it'll be necessary to turn off the lights right away. Maybe it would help if we could cut these lights, so that doesn't throw something else off. This simply shows a map of the state of Iowa. The black dots are family practice residency programs in the various communities that are tied together in what we call a statewide network. It's been set by law through the Iowa legislatures, and it's been somewhat supported by the legislature. About 17% of the program is supported by state funds. Also on this map are some other little designations, and they are satellites of one type or another. The Davenport program has family practice program has a satellite office in DeWitt, and we have a special program out in Red Oak and Malvern, Malvern being the satellite from Red Oak. And the Cedar Rapids program has a satellite in Mechanicsville. Bob Riggle has one in Williamsburg. Some of these are real and some are artificial. That is, the Red Oak Malvern is real. Williamsburg is artificial. Without the residency program, the unit could hardly survive in Williamsburg, at least as it's presently constituted. On the principle that where a physician takes residency training is where he or she is likely to locate when he or she enters the practice. Incidentally, that was a very simple question before my feminist secretary got a hold of it, but the Iowa plan was geared to produce enough family physicians to correct both specialty maldistribution and geographic maldistribution in one maneuver. Now, specialty maldistribution refers to too many of one kind and not enough of other types of physicians. The health policy, whatever that is, of this country indicates that we need a balance of about half primary care physicians and half other kinds. And once corrected, then there will be primary care physicians that go to those places that can only support primary care physicians, and that will correct the geographic maldistribution. Now, this was our premise when we started 7 years ago with this program, and I'd like to give you briefly in the time remaining what the outcome has been. Now, progress to date shows that this is really happening. There are now over 138 residents training in family practice. I could have the second slide. Will give you an idea of the rapid growth, if you will, of this specialty in terms of residents in training. We're out there on 77, 78 with 139 residents in training. We started in 1970 with no people in this specialty. And furthermore, medical students are turning to this specialty in increasing numbers. And the next slide shows what has happened to the graduates of Iowa in terms of family practice. Starting out 3% or 4 students going into the specialty. This last year, there were close to 40 or 25% of the graduating class going to family practice. I might add that along with this has been an increase in the number of students going into internal medicine as well as into pediatrics, so that now 70% of our class has been entering programs upon graduation that are identified as primary care. The next slide, please. This shows another phenomena that has occurred, and that is that the graduates of University of Iowa are staying in Iowa for graduate training, whereas only 8 students stayed here in 1970. There are now 66, and the shaded part shows those going to community-based programs, most of which are family practice or general internal medicine, and the balance to the university hospitals for the various specialty training programs there. Those completing their training are remaining in Iowa and increasing numbers. And further, they are distributing themselves evenly between the towns of less than 10,000 population and those above 10,000 population. And the next slide shows you what happened to the class of 76, 24 graduates from the program in family practice, 15 remained in the state, and the balance went to the other places, 3 to the West Coast, none to California. We thought that was pretty good. And those that didn't go to the West are in surrounding Midwestern communities. Now, you can't read this scale on the left, but many of those outside the state are in towns of around 10 or 11,000 population. And the next slide will show you somewhat the same thing. This represents all the graduates from the program, whether they stayed for 1 year, 2 years, or graduated. The half circles are less than 3 years. And the dark dots are in communities of less than 10,000, and the hatched ones are communities above 10,000. If you were able to count those out, you'd find they're about evenly distributed. And the next slide simply says this in a graph way about the same thing. 15 resident graduates in 76 stayed in the state, and 20 out of 38 in 77 with a 63 or 53% relationship. And this and other programs seemingly have reversed the trend toward physician depletion in Iowa, and in 1977 we can show that there are now 82 more physicians than there were last year. The next slide doesn't report to that, but does report to what happened in terms of family physicians entering practice in the state of Iowa last year. 37. 20 of them came from the in-state program. 17 came from out of state. Some were our graduates who had training elsewhere, and some were from the College of Osteopathic Medicine. 3 of them are graduates of the osteopathic program. And the black dots represent, and the half-black circles represent towns of 10,000 and less, and the hatched and the arrow represent towns of greater than 10,000. And this represents rather even distribution throughout the state with a slight weakness, if you will, in the far western part of the state, although southwest seems to be reasonably well represented. Now, most primary care is ambulatory care, and in the United States, this means over 60 million visits a year, or about 3.1 visits per person per year. And the next slide is from the Center for Health Statistics. All specialties, 600 million visits, and the most or the highest number of specialties with the highest number of visits are listed, and general and family practice represent 40%, internal medicine 10, pediatrics 8, obstetrics 8, and general surgery 6, and the rest of the visits would be split, which represents about 25% among the other specialties. Now, 15% of the visits are generally first-time visits, which is some index into the accessibility part of the issue, and 65% are associated with symptoms. The other, and over 60% of the service is provided by the primary care physicians of internists, family physicians. Now, the next slide simply tabulates a matter that is often discussed, and that is, why do people go to a doctor, and do they all have to? And I think if you just go across the top line, the internists find that 29% of the people have serious or very serious conditions, and 33% slightly serious, and 38% are not serious. Now, that's not to say the 38% should not visit the physician, but the checkup population and the required physical examination population, et cetera, fit into that 38%. And another thing that this kind of data does not reflect, and that is, when the patient walks into the doctor's office, you don't know which classification he's in. One of the processes that goes on at the primary care level is to classify him into this area. So you can't play too loosely with statistics and say, well, 38% of the people don't need to go to the doctor, and so we can cut the system down by 38% because they don't need the services. The primary care physicians tend to have long hours, and the next slide show that the median hours per week is about 60, and that the number of patients are quite high, and the next slide will show that the average week for a primary care physician represents somewhere between 1 and 200 patient visits. You can get all kinds of statistics on this depending upon whether or not the physician alone has been involved in the visit, or allied personnel within the office have been involved. But these figures are pretty close to the maximum side of that question. Now, to accommodate to this kind of load and continuous responsibility to the community, family physicians are forming groups in larger rural communities, 5,000 population or thereabouts, and covering smaller communities, 1,000 population or thereabouts, in nearby towns, with satellite arrangements which include intermittent physician visits, improved transportation for patients, and or physician extenders in residence in these satellites. And the next slide simply shows what a group of doctors might look like, and the ringer there is Dr. Rakel in the middle, but the other 5 physicians represent a group that was formed in Red Oak to model out the phenomena I just described, which those of you who are familiar with Dr. McQueen's work of some 7 or 8 years ago represents his regional primary care center grouping of physicians. And the next slide will show you what the office looks like these people are working in, next to the local hospital in Red Oak. And the next slide is a picture of the satellite in Malvern, where the physician assistant functions from about 10 in the morning until 5 in the afternoon. At 2 in the afternoon, the physician from the group comes to the town to check up on problems not handled by the physician assistant. And on weekends, on Saturday, the physician assistant goes back to the group and works in that office to maintain his skills and relationships, professional practice patterns, and so on with the group. Now, the effect of all this has been to keep and evenly distribute Iowa-trained physicians in Iowa and to attract physicians trained elsewhere back to Iowa. You will note in the previous slide that there were, or some slides back, that there were some 17 family physicians who had come to Iowa to practice in the past year. Now, it's the opinion of this speaker that the key manpower problem in providing primary care is fast being corrected, namely the reinstatement of the family physician into the healthcare system, particularly here in Iowa. This accomplished, the addition of allied components of the team can be more or less easily fitted into the system, as can the other components of healthcare, which will be distributed or discussed by my associates here on the panel. Thank you.
Okay, we'll open it up briefly now to some questions. I think you all have a better idea now of the impact of this family physician program, and it really is significant to the health care of Iowa. Do any of you have any questions for Dr. Seebohm at this time? All right, if there are none at this time, we'll move along to our next presenter and remind you that there will be an opportunity after all of the speakers are finished to ask questions also, and we hope maybe we can get some discussion going as time permits. Our next speaker will be Dr. William R. Bliss, who is a practicing physician now here in Ames. He went to University of Iowa Medical School, graduated from there, did his residency at Ohio State. He is currently the secretary of the State Medical Society, and he's the former chairman of the Governor's Advisory Council on Emergency Medical Services. He will be talking to you about emergency services here in Iowa. Dr. Bliss.
Thank you. Mr. Chairman, ladies and gentlemen, I gladly accepted this opportunity to participate in this discussion today because I believe emergency medicine needs all the exposure that it can possibly obtain. I would like to divide this presentation into three sections. The first section, I'd like to explain and define what emergency medicine consists of, or what it covers. The second part, and both of these will be rather brief, will be a discussion of what has been accomplished in the state of Iowa, and then the third portion will consist of, and be a little longer, but will consist of what I think needs to be done in the state and what I hope will be accomplished in the near future. Emergency medical services covers that portion of the medical experience which originates with a medical emergency and includes the patient care until the patient is definitively treated or has been admitted to the hospital after being seen in the emergency room. Although there is some controversy over the subject, it also involves many critical care units within the hospital itself. The system involves a recognition of the emergency. It includes communications to the appropriate agencies, medical and public. It includes the ambulances, ambulance personnel, rescue technicians, emergency rooms, emergency physicians, and nurses, and so forth. In fact, it addresses 15 components in all, which I'll discuss later. It includes a segment of medicine in which there is a staggering loss of life and money. Statistics placed before a United States Senate Health Committee on February 1st, 1973, claimed that 18,000 accident victims and 350,000 heart patients could be saved annually with better emergency medical services. In this state, well, as sort of as an arbitrary rule of time or time lapse, it's been accepted in the United States that 30 minutes is the maximum time lapse between the receipt of a communication identifying a medical emergency until the arrival of a van with well-trained personnel to take care of that patient. In the state of Iowa, we have set our goal at 20 minutes, figuring that if we could get the van to the emergency patient in 20 seconds and have capable personnel start definitive therapy, we could more greatly reduce the loss of life and subsequent suffering associated with medical emergencies, and also thus lower the mortality rates. This, we figured, would give us about 1 hour time elapse as the absolute maximum between the onset of the emergency, the identification of that emergency, the receipt of the communications, and the arrival of that patient at a suitable medical facility in the state where he could be adequately treated. In spite of all this, emergency medical care has been one of the most neglected present-day segments of present-day medicine. In addition to decreased loss of life with improved emergency medical services, there would also be a marked decrease in permanent disability and associated pain, suffering, and monetary loss. And very briefly, I just want to refer to the plan that we used. It quotes some figures which indicates that up to the age of 44, the leading cause of death in the state of Iowa is accidents, and after that time, it's cardiac problems. And these are both the prime sources of patients into the emergency medical system. Although the aforementioned facts have long been recognized, little progress was made in emergency medical services. This was especially true in the less populated regions such as the state of Iowa. Because of the obvious low caliber of emergency services in many areas of the country, the Secretary of Transportation decided to take action. In 1966, the Secretary attached a condition to the National Transportation Act of that year, which required states to take steps to improve the situation if they were to continue to get federal funds for highway construction. One of the requirements included that of establishing a plan for emergency medical services. I'll not go into all the details, but in the state of Iowa in 1971, a meeting was called in the city of Des Moines. It included individuals from throughout the state that were interested in emergency medical services. Of course, many medical organizations and other organizations were represented at that meeting. And one of the results of the meeting was the establishment of the Governor's Emergency Medical Services Advisory Council. The Advisory Council was made up of 15 individuals and included both providers and consumers of emergency medical services. The members were appointed by the Governor. The council was staffed by 4 men who employed 100% of the time in emergency medical services. This organization was given the objective of developing a plan for the state of Iowa and emergency medical services. Now, briefly, I want to mention a few of the output from this group in the past few years, and then go into the and finish up with what has been accomplished, and then start in with the third section. The output of this group includes the following accomplishments. 1, training of 4,200 EMTAs. Now, this was as of about 3 months ago and does not include the summer courses. This means emergency medical technician ambulance. In addition to this, 5 hospitals in the state of Iowa are training EMTAs in advanced courses. Now, this is a much more sophisticated area of medicine. These fellows, or both men and women, are trained in the starting, I should say these persons maybe, are trained in the starting of IV fluids. They're trained in the interpretation of cardiac arrhythmias, and not only the interpretation, but the treatment of these conditions. They're trained in the passage of endotracheal tubes to establish airways for the patient. So, with this group available, in the matter of usually 3 to 7 minutes inside a city, or less than 20 minutes in the rural areas, there are capable personnel available to maintain life until this patient can reach the emergency facility in a hospital, which we expect to be staffed with sophisticated personnel to continue the support. There's also been a trained 225 emergency rescue technicians, and briefly, these are fellows trained more in extrication or handling of the removal of patients from situations where they need power equipment, etc. There have been partial funding of 70 fully equipped ambulances with 185 new ambulances in the state of Iowa. And when we speak of ambulances in this case, we're talking about ambulances that have room for these trained personnel to work in. They have equipment as prescribed by the American College of Surgeons and accepted by the Governor's Advisory Council. And they are arriving with 2 or 3 EMTAs, again, emergency medical technicians ambulance, who are trained in life support. There have been 100 two-way radios that have to be used for emergency medical services. None of these are included in those radios and ambulances. A comprehensive communication plan for the state of Iowa with functioning systems now operating in central Iowa and in the Hoover Health area. There are 16 regions in the state of Iowa, communication regions, and 2 of these are operating now. This involves a rather marked outlay of capital. 6, there's categorization of the hospitals in order to determine what our state capabilities are and to index these for future reference. These include the whole field of emergency care plus that of critical care areas. We have made on-site visits in all of the 140 hospitals in the state of Iowa. These hospitals have all been categorized as to their abilities to accomplish emergency medical care. Number 7, statewide emergency medical services plans, which has established the entire state of Iowa as one emergency medical service region with the state divided into subregions. The Midlands area in southwestern Iowa is included in the Omaha, Nebraska area, and the 2 counties, Scott and Muscatine, on the east end of the state are included in the Iowa area with about 5 counties in Illinois. This plan is called an umbrella plan and was adopted because of advantages in funding, administration, more efficient use of expert personnel, and it's working that way, and I'm not going to spend any time elaborating on that. Can I have the first slide, please? Can you see that all right? This gives you an idea of the sub-regions. As you can see, the state has been divided into 5 sub-regions. As I mentioned, the 7 counties in southwestern Iowa are in with the Omaha, Nebraska area. These areas now, all but one, have central offices with project directors or project administrators and secretarial help. They will be recipients of grants called 1202 grants to develop this planning and adopt, to set the plan, implement the plan really, so that a system can be developed in these regions. By the 1st of October, 4 of these regions will all be operating, and 2 of the regions will be into what's called 1203 grants, which I'll explain in a minute. And the last one I talked to Mr. Carson this morning, and their council is formed, and they're interviewing now, and within a couple of weeks they expect to have the last region will be staffed. Next slide, please. This slide is divided, because of its length, we had to divide it into 3 different slides in order to present on the board, and this just explains first that the EMS Act of 1973 required the plan and development of these regions. Next slide, please. This shows that this mentions that Act of 1973, and then the fact that in 1976 new legislation was passed authorizing the expenditure of more money. Next slide, please. This here is a picture of this description of the grants. In the 1202 grant, the first one amounts to $45,000 now in the state of Iowa. They have dropped those down some, and this is what's allowed to each one of the regions for planning. Subsequently, the 1203 grants extend over 2 years, and therefore more implementation, and they are grants from the federal government, which are matched by what they call a soft match in the state of Iowa. Generally speaking, not a hard match. So dollars aren't matched exactly, but by meaning a soft match, the use of personnel and can be used according to a formula to end up matching the funds as donated by as produced by HEW. 1204 is an extension, an expansion of the systems, and I think that they plan now, as I understand it, to add another year there. 1205 is our grants for research grants for, especially for rural areas, to try to develop more satisfactory systems. Have the next slide, please. Now I want to come to the. This part is just quickly, it's a division of the money as to the 242 million. As you can see, most of it's going for a systems development. Some will go for research, but the systems development and training are the two largest recipients of funds from that authorization. Next slide, please. Now I come to the most important part of my presentation, and I want to go through this to explain what is involved with the development of an emergency medical system and what faces the state of Iowa in getting into operation a operating system. This is what we feel needs to be done in the state of Iowa before these systems can be truly operable. The first is manpower, and I think that's quite obvious that there are many fields that have to be filled with manpower. Now, the 4,200 EMTAs are a good start. Now, whether this satisfactorily covers the state of Iowa cannot completely be decided until the regions are operable and they find out what their needs are. In addition to this, as I stated earlier, there are advanced EMTAs trained along the paramedic lines now who will be able to administer more sophisticated care. There will be the need to train more physicians and nurses through courses in emergency medical services. I hope that someday, if we're really going to handle cardiac emergencies, that practically everybody in the United States will be able to deliver CPR or cardiopulmonary resuscitation. In order to do this, one of the suggestions that I made that the State Patrol dropped like a hot potato was that everybody who gets a driver's license would be required to pass cardiopulmonary resuscitation or basic life support. They didn't think that was such a good idea. If, however, if everybody who got a license and everybody who recertified their license or driver's license had to pass CPR, then most of the country would be trained, and there wouldn't be anybody that was dropping over in a company such as this that would not receive basic life support immediately. However, some of these problems, of course, will have to wait the evaluation of the subregions, and then they will make recommendations to the umbrella organization, which in turn will help them to get the necessary manpower. And since we expect that about 20% of the emergency medical technicians and ambulance, I keep repeating that because if I say EMTAs, I'm afraid that some of you may not follow. I know when I started into this, it took me about 2 years to understand what the people from Washington were saying. And if I got into a small room with them, I'd have to have them run it by a couple of times. So when those abbreviations come out so quickly. The next one is training. And here again, in Iowa, the EMTAs are being trained through the area community colleges. Now, the area community colleges are charged with the administration of these programs. The faculty are largely made up of physicians or other EMTAs who are trained in this field. On our program in Ames here, through the summer, the program that was put on for training more EMTAs, the fee for taking the course was $100. Then you purchased your own teaching aids. It varies in the state of Iowa between about 80 and 140. The faculty here was 3/4 physician and 1/4 advanced emergency medical technician to ambulance. The courses the curriculum is quite well established, much more standardized than previously. The testing now is getting quite standardized as to what these people need to know. We hope that there will be certification for these people, which may necessitate legislation. This certification, we hope, will receive reciprocity, so if you're certified in this state, you can go to any state in any of the other 49 states and be accepted as EMTA, EMT-A or EMT-A advanced, and go to work there just as without any further problems. We hope that next year there will be the courses put on for the physicians and the nurses, and we hope to have, maybe I mentioned earlier, I have it down here again if I did, there's 800 MDs and 1,400 nurses we hope will be receive courses next year in emergency medicine. The next one is communications, and of course this when you get down into systems, this is the problem that you have. You can't leave out any of these, especially the first ones, and have any kind of a functioning system, because the emergency has to be recognized, and as soon as it is recognized, the proper authorities have to be notified. So this is a problem that has been especially a great problem in the state of Iowa. The change in the bands have gone from the regular bands up to a VHF band, and in the cities are going to UHF bands, which gives you more frequencies for telemetry. But in the state of Iowa, we're using a VHF band, and this is an accepted frequency throughout the entire country, and that's 155.340. So any ambulance going across this country now can communicate with other ambulances or emergency rooms as they cross the country. Our 16 regions will have the ability, each will have their own frequency, so they can communicate between themselves in that region or with their emergency rooms. These vehicles will also be able to communicate with all the I guess the public agencies such as police, fire, etc. And this will be through 155.475. But they all have these capabilities so that they can contact other ambulances and emergency rooms. Now, in Ames, in this state, there are 2 regions functioning at the present time. One's around Cedar Rapids, and one's around in central Iowa. It's the Hoover Health District area in Cedar Rapids, which includes Iowa City, and then the 7 counties around Des Moines here, which is called Central Iowa. In Ames now, we have a 911 call letter, or you can call the operator, but you can get right into the emergency system that way. Our EMTAs have the ability with walkie-talkies to to converse with any doctor in town or with a coronary care unit or with the emergency room by radio through a phone patch, so that they can contact any consultation that might be necessary through this phone patch. And this is what we want in in all the communities in the state of Iowa. Our EMTAs here have been underwritten by the medical staff, so that the liability is assumed by the medical staff. This ability to communicate again through directly with a physician will certainly, I think, reduce that liability. However, the development of these areas will have to come through the 1203 grants, and it will mean that it's quite an outlay of cash. For the Hoover area came through IRMP, the Regional Medical Planning Program, and the Central Iowa came through a grant from a private corporation. The next one is transportation, and here we hope that that we will have adequate vans, as I described before, that these vans will carry at least 2 or 3 trained EMTAs, 3 in the case of a coronary problem. Again, we hope that these will have the equipment as designated by the State Department of Health and the Governor's Advisory Council as to the necessary equipment aboard. And although this may require some legislation before we can guarantee everybody in the state of Iowa that they're going to have the arrival of this vehicle with this kind of personnel in this many minutes, it may require legislation, but that has been very difficult to get any support for this type of legislation so far. It may be on a voluntary certification basis, much as medicine has used in the past, but we hope that that will be accomplished. As far as facilities are concerned, as I mentioned earlier, we've been in the emergency room facilities of all 140 hospitals in the state of Iowa. And many of these will need to be improved, or we hope they'll be improved, because most any medical facility could afford to be improved. Again, there may be some legislation that will concern itself with licensure as to what is necessary to maintain a adequate facility. It also, or it may be entirely dependent upon the emergency councils for each of these subregions to evaluate their own emergency rooms and then to either recommend improvement or okay them for continued operation. We tried to put this on computers. We got a grant from RMP, and it can be done, but it's so terribly expensive at the present time to do this type of operation, so you could evaluate the operation of the whole system this way, and maybe, I think this is what will happen someday. The cost effectiveness, whether we're doing the public any good, we feel that we've done a great deal of good, but we could really evaluate this by the use of computers. However, that's a ways down the line. The critical care units in the state of Iowa, and I won't take too much more of your time because these will go rather quickly from here on. The critical care units that have been addressed in the state of Iowa are those of trauma, with burns and neurosurgery. There's cardiac, there's poisoning and detoxification, neonatal, and psychiatric. Now, the evaluation has been a self-evaluation process at the present time. This will be turned over to the subregions, and this must be done in order to have these critical care units covered satisfactorily within a certain time span, depending upon the type of critical care, so that these ambulance personnel will have the ability to decide, triage the patient, determine what shape the patient's in, what the patient needs, and head for the nearest facility that is capable of administering this kind of care. The public safety agencies, as I mentioned before, are within our communications, on our communications system. They work on a 155.475, and so we now, when we get our communications working, each ambulance will have the ability to request cooperation and help. And of course, they've always had cooperation. Usually, these agencies are already on their way, and they may be there before the ambulances are. So in our training program, this includes the police, the state patrol, and fire departments, and so forth. They're getting basic life support and also getting a course quite similar to those that the EMTAs get. However, as you notice all the way down the line, everything I talk about takes money. And you've got to get hold of the money some way in order to get it. Now, most of it is coming right now from the federal sources, or from county board of supervisors, or from what the hospitals have. If you take the whole operation, then you would have to consider that each hospital that maintains a good emergency room is making a donation into the emergency medical system. I think in the future it'll have to come down to some sort of capitation with funding on a local basis, or possibly on a local basis through the state organization, through the state administration. Consumer participation, of course, this is absolutely necessary to get a good operating system. You need consumers to determine whether you're giving them the kind of coverage that they feel that they want to get their expertise in developing these systems, as well as understanding how you get into the system, how does it operate, so that people will become more aware of what we're trying to do and will know how to call for help and how to get help for their neighbor. Accessibility of care. Oh, would you give? Yeah, good. Somebody changed it. On accessibility of Bob. This is of course, there is not to be any restriction of access to this system. There's going to be no attempt to bar anybody from this system, whether they have the money or whether they happen to be a resident of this state and so forth. That if the patient needs care, then they're to get care. Transfer agreements will be arranged between the hospitals so that there will be no delay, and if the patient needs more sophisticated care, the triage will be performed in that facility. If they don't have those capabilities, then the patient will immediately go to a hospital farther along the line in which agreements have already been established. Standard medical record keeping obviously will be necessary because these patients will be moving along and the records will have to be the same. It will also be necessary for evaluation. So here again, we are developing a record that can be used no matter in what portion of the area of the state that it is started or written out. It'll be the same in all sections. The next thing is public information and education, and this is much the same as my early consumer participation, except for one thing. We need to spend more time and money on trying to develop methods of averting accidents, not only cardiac emergencies, but also the training of people so that there are not so many types of accidents. For instance, I admitted a patient the other day from the same family that was burning garbage with gasoline, well, with an open gasoline container. Well, in our book, that's a no-no. I mean, we tried the first time around, but this has happened the second time. Now, there's an emergency that's occupying a fair amount of our time that really is quite unnecessary. The evaluation, of course, I've mentioned that all the way through this discussion. And the disaster linkage and mutual aid agreements are between regions and between hospitals and physician staffs, and including all the personnel involved in these systems in order to share their equipment, their capabilities and time, etc., depending upon what happens in either region or hospital area. That includes the components, but this is why we say that you have to have a complete system. If you don't have the communications and you've got the best trained personnel in the world, it doesn't do you any good. You don't get there in time. And if we have a cardiac emergency and there isn't somebody close by that can start pumping the chest, you only need 4 minutes, and there's no use to pump it. So you can see that there is a necessity to have the people available, to have the communications, and the whole system is necessary to make it do the job that we want it to do. Now, the last one I mentioned is not on these components, but there's the possibility of legislation in the future, and this is quite an involved problem, at least here in the state of Iowa. We will need to have some legislation to recognize the medical activities of the ambulance technicians. This is especially true in those who are certified as advanced ambulance personnel. At the present time, they are being underwritten in our hospital by the medical staff. The medical staff assumes the responsibility. We also need legislation to finance and support these systems I have mentioned above. It seems to me that in time, these systems should fall back upon the state or local people to finance their continued operation. This also will require legislation. Thank you very much for your time. That completes my presentation.
Okay. Thank you, Dr. Bliss. Does anyone now have any questions for Dr. Bliss? And I might mention that he has to go to a meeting, so this will be your only opportunity to ask questions about the emergency medical system.
advantage to this, of course, will be that if the EMTA has a question, or he needs, well, as an example, say in the middle of the night he finds a patient with an accident whose face is crushed. He maybe has passed an endotracheal tube, and we've had that happen, in which formerly these patients did not make it to the hospital. Now with an adequate airway, they're coming in. But he needs somebody there to, right away, he needs a surgeon there waiting with an anesthesiologist or so on. Or if it's a cardiac emergency, he needs to have the internist there, or he needs advice. He can call them by this and tell them what the problem is and ask for advice on the way in as to what medications are used in the case of cardiac, say, an arrhythmia. He may want to talk to the doctor about the use of certain types of intravenous medications. You have an IV going, and get his advice as he's coming in, all the way in. Because they'll have a running ECG on the patient, for instance, or they'll be running pumping the fellow, but see, he has a problem breathing even after they get the endotracheal tube. He'll want somebody there as soon as he can. So he wants the right person there, too. He just doesn't want any doctor there.
Have you had to give up the night a lot of times then?
Well, not much I used to, I don't think. We got more doctors around now.
Well, you probably just go and do that.
Yeah.
Any other questions? Okay, thank you, Dr. Bliss. All right, I think we're due for a small stretch. Oh, you have a question?
Doctor, I'm just curious, how are the problems of professional liability work out?
Well, the only thing, and I don't think it will change, is that I don't think that you're ever going to be able to legislate responsibility in this. I think that the EMTA, they have a law in Nebraska that I read last night, which indicates that as long as you operate within the normal boundaries of what's called reasonable medical practice, that these people who are paramedics or advanced EMTAs are a recognized legal entity, and they will not be considered liable or committing malpractice even without any of course, okay or permission from the patient. Of course, many times you can't get it. Or from a relative. And if the relative is there, or the patient is able to talk, they are still liable. They have to get the permission to go ahead and treat the patient. And I don't think they've ever had any trouble. But it seems to me that they'll always have to be underwritten by a medical staff. Somebody has to have decided that this doctor, this paramedic is capable of doing this, and be willing to go on the line and say he is. And then that way you have to assume responsibility. I don't think they can ever change that. They may be able to through legislation. Yes.
Opening up, that there will be more opportunities for people to be involved in this field, rather than just perhaps career opportunities, etc. Rather than maybe drop what we have and maybe more coming in.
Well, you mean in the turnover? There's a 20% turnover that I mentioned. No, we're training new people all the time. In fact, we try. And then attempts was made to restrict this to people first who had definite assignments to ambulance crews, or could expect a job when they get through. Now that has been dropped, and with the turnover of 20%, you're going to have an opening frequently, because these fields are not, the remuneration for doing this is not the kind that's going to tend to hold people into the field in a great many cases. And that these will probably, well, I feel that these are very well-trained people who are ready to go at any time, and they should be very adequately reimbursed for their time. But this is rather difficult to do, and it'll probably involve insurance of some type before you get up there. So in many cases, it's a volunteer effort, and then there's a constant turnover, so that there's always new people coming into the field. And you have to continue to be recertified every 3 years. So, it's just going to, depending on how much exposure you have to emergencies is how well you function. Does that answer your question?
Yeah.
I don't think you have any trouble really just applying and getting in as soon as the course opens up.
We have one question over here.
Bill, how did those people in the paid career, in emergency medical service, how do their incomes and life compare to that of, say, firemen who, in a sense, have a somewhat similar kind of life of long waits and great excitement to the other thing?
I saw Mike Stevens here, and he just laughed. I could ask him that question. He heads up our Mary Greeley program, and it's my opinion, Paul, that I'm not sure what the firemen get paid. That's where I would have trouble. But so far, as you know, around the hospital, when you take one segment of your population and start to push them up, that is just opening up a great deal of controversy for the hospital administrator. He frowns on that sort of thing because then the whole operation goes around. And so it's difficult when you are employed as our people are by the hospital to increase their financial return to one segment. I'm not sure where, I don't think they're as high as either the police or the firemen in our town, and I don't feel that they have the fringe benefits that the others have. We use them in our hospital, just briefly. We use them for a great many other things because we thought that idle hands are the devil's workhouse or something like that, or playhouse or something. Anyhow, we use them for around the emergency rooms. They are involved in the ECGs, taking electrocardiograms. They are involved in security, and there are usually 4 of them there all the time, and they are a great help.
So they are really doing other jobs.
Yes, quite a few others. I called about our charges. I called John Worley last night, and our average run of a cost of a vehicle call now is $100 for if it's a coronary call. It's $40 if it's say an accident call, and then they figure that this includes